Okay, well, I don't see myself, but anyway. Well, good afternoon, everybody. I'm really sorry I couldn't be there in person. I do want to extend my gratitude to the Epilepsy Foundation, Andrew and Raina, and everybody else to give me this opportunity to chat with you a little bit about the transitioning in epilepsy care. You just listened to a very empowering talk for the young adults by Dr. Freed. And full disclosure here, I am a child neurologist and a mama bear. And so today I'm going to talk about the people who will have to do the letting go of these young adults. So let's see, can we start the slides? So yes, I am Dr. Akila Venkataraman, and hold on, there we go. Is it letting me? There we go. Okay. Sorry. Oh, I'll get the hang of this soon enough. So, as I mentioned, as a child neurologist, we typically have very long-standing relationship with our patient and patient families, and that typically may span the entire childhood and adolescence. So we start seeing the babies as they come out of the womb and, practically raise them along with their families. And so the attachment between child neurologists and their families is very complex, and it's a major factor in the transition of care. There have been so many milestones and experiences that have been shared over the course of the relationship, which deepen the comfort and understanding between the two. I can tell you personally, I have had the honor and pleasure of seeing some of my babies grow and develop over the years. I've attended their kindergarten stepping up, their confirmations, their graduations, and I've actually even attended a few weddings of my patients. That's when you know you're getting really old. I think the next step will probably be seeing the babies of my own babies. But anyway, that having been said, how a child neurologist is actually trained to look at the child brain is a little bit different than how adult neurologists are trained to look at the brain. In child neurology, the perspective is that of developmental monitoring. We completely watch that brain just transform over the time of our care of the patient. And again, it's a whole different brain and biology that child neurologists deal with compared to their adult counterparts. So I often joke that, as a child neurologist, I'm almost like a veterinarian because I take care of brains in their newborn period, as infants, child age, adolescents, preteens, adolescents, and young adults. And none of these brains are like the other, even in the same individual. So an infant brain is not actually like a teenage brain. And so our perspective is one of monitoring that development and really allowing for those changes to happen. And as I trained both as a child and adult neurologist, that was the major difference in approaching my patients. And so I think that what the young adults with epilepsy see from their child neurologist is slightly different, even in training, from their the adult neurology counterparts that they will be seeing. So now, as I mentioned, we look at the brain very differently in child neurology because not only is that individual different as a baby and as a child and as a preteen and a teenager, even the manifestations, the type of seizures, the type of epilepsies, and their testing, everything is actually very different in a child compared to an adult, right? And so because we are treating different pathologies, different signs and symptoms, and different types of epilepsies in the child as we are compared to what we treat in the adult, the treatment modalities and the approach to management also changes. In fact, one of the most striking differences that happens is probably in the EEG itself. So when we start reading the EEGs of babies, particularly preterm babies, premature babies, if there is a change in the basic EEG structure, and it changes every 2 weeks almost in very premature babies. And to be able to understand that change and what is normal and abnormal for that particular patient's age is something that child neurologists are pretty used to. And all of that, actually, those changes sort of stabilize, and finally this young adult emerges, and from there on, their brain, the way their EEG is read and manifests, is all pretty stable. But there have been a lot of changes that have gone in the first part of that patient's life, including other tests, the kind of tests that we do, whether it's genetic testing, blood work, the MRI structure may change as the patient grows. So, as I mentioned, when we're looking at these biological changes that happen across the ages in an individual, we're looking at, let's start with the formation of the brain and the foundation of the brain, right? When the baby is born, what does that brain look like? What does that brain act like? What is that brain's blueprint? What does it intend to do? What is that baby's personality going to turn out to be? What is that baby's seizure pattern going to be? All of this happens from the very formation of that brain, and the genetics of that patient forms the blueprint. And since we, as child neurologists, are the first people to start evaluating this in our own patients, we start looking at, congenital anomalies. Is the brain formed, normally? Are there any malformations? Is there any genetic component, any genetic mutations that might make this baby more prone to seizures? What is the otherwise neurological functioning of this baby's brain? So so this is the basis of how we start taking care of our patient's brain. And we follow these biological changes, which add to the complexity and transition, right? we've seen this baby's brain grow and change in structure and function. Normal physiological development stages in adolescence may actually be disrupted by epilepsy. So we are following that child, normal growth, normal development as they become a teenager. And there are a lot of biological changes that happen within the body at that time, but more so in a patient's brain that has epilepsy. We do know that certain epilepsy syndromes are very age dependent. In fact, as we try to think about how that person's brain is growing naturally, is developing, we start considering all the changes that are happening with age as well. So for example, there are a lot of biological factors that impact a person's epilepsy along the age group. So for example, impulsive pleasure seeking and risky behaviors are seen as part of normal adolescence. Puberty has a major effect on development, personality, and behavior. Sexual debut is early in youth with epilepsy, and long-term sexual experiences actually may be impacted by epilepsy. The degree of risk for and mechanisms of bone disorders in childhood onset epilepsy are also complex. So there are a lot of different biological factors that we have to take into account in this transitional period from adolescence into young adulthood. Now, as I mentioned before, child neurologists are pretty familiar with what we call age-dependent epilepsies. So I like to think about epilepsy syndromes as happening as part of their developmental age. So for example, we have seizures that happen in the neonatal period. And a neonate or a newborn's brain is very different, what it can do and how the seizures actually present themselves. And that in and of itself is very different from a young child, school-age child, or even a teenager's brain and the type of epilepsy that those brains actually manifest. And it's funny because we have this term, childhood epilepsy. So we kind of think about certain epilepsies as happening only in childhood, and maybe they grow out of it per se. Whereas some of these epilepsies start in childhood and then persist into adulthood. So there's a very different aspect of epilepsy that the adult neurologist actually inherits from the care from the child neurologist. Oops. Hold on. Can you advance this slide? I can't seem to advance. Oh, here we go. Okay. So when we talk about childhood epilepsies, we have a lot of different types of epilepsy, right? We have focal epilepsies and generalized epilepsies. Interestingly enough, focal seizures are actually more common than generalized seizures in both children and adults. All right. And the one thing though, it seems like generalized seizures or generalized epilepsy is more likely to present into adulthood with a childhood onset. I suppose some of you might have heard of some of the more focal epilepsies of childhood, which typically might have a more benign course wherein they actually outgrow their epilepsies by the time the child reaches adolescence. And so those are the childhood epilepsies that we talk about that the adult epileptologists may not actually even take into consideration most of the time, because they don't necessarily deal with those type of epilepsies. Now, there's an interesting statistic where 1/3 of the patients with childhood onset epilepsy actually can experience seizure improvement following transition to adult epilepsy care. And these type of patients are those who are the young adults who started with childhood onset epilepsy at a younger age and have been maintained on less anti-seizure medication, suggesting that it's just a matter of time as they transition into adulthood. They will actually tend to do much better because their epilepsy has been under control from the beginning. So, interestingly enough, over the last few decades, the age-specific incidence of epilepsy has actually decreased with time in the youngest age groups, meaning childhood epilepsy, the incidence has actually decreased. And that's probably because of the reasons of control of reasons that cause some of the childhood epilepsies and childhood seizures. For example, we're able to offer better perinatal care to the newborn. You know, we have medical technology and advancements that takes very good care of even the most premature babies, and thereby improving their health. And, you know, some of the infectious diseases and other causes that might actually be responsible for some of the epilepsies that we see in young children, that's been improved. And so the incidence of epilepsy in that age group has actually dropped. Incidentally, the incidence of epilepsy in the elderly on the other end of the spectrum has actually increased a little bit. But that's probably, again, because people are living much longer and are actually surviving and doing well, but still having to face some of the conditions like strokes and degenerative diseases, which are likely to cause seizures and epilepsy. So we do know that epilepsy, the incidence of epilepsy and seizures is much higher on either end of the age spectrum, much higher in the youngest of children and the more elderly. And so overall medical care for each of these age groups has changed and improved over time, thereby changing the incidence along this age group. Now, here's the thing. You know, we have to take into account the complexity of the epilepsy itself when we're considering the difficulty in transition. So the content of transition programs for those with normal intelligence and otherwise normal functioning, neurological functioning, differs from those who have an intellectual disability or other developmental disabilities associated with their epilepsy, right? So, for example, matters become a lot more complicated in more rare and complex epilepsy syndromes with comorbid intellectual and developmental disability that actually complicates, the resources that they will need, what else needs transitioning, not just your simple epilepsy care, but everything that comes along with that. Now, one of the reasons that I think the care becomes a little bit more complicated, especially in complex scenarios, patients with a complex epilepsy syndrome and or other comorbidities. As a pediatrician, I noticed that care in pediatrics, we actually have a lot more integration between the medical specialties. For example, as a child neurologist, I actually am in constant conversation with my other pediatric colleagues, whether it's the general pediatrician that's taking care of my patient, whether it's the GI specialist or the lung doctor, the stomach doctor, the blood doctor. We tend to, all the pediatric specialists tend to be in conversation with each other a lot more than adult specialists. Because in general, pediatric complex care involves all of these specialists. As opposed to in adult medicine, you typically have your adult epilepsy providers who may integrate some care with their PCP, but for the most part, it is, neurology care is limited within a neuroscience complex. And not so much with other specialties. So, this tends to make child neurology practitioners more likely to deal with complex issues that extend beyond the medical, extend beyond just prescribing the medication. We end up, dealing with a lot more educational, behavioral, emotional, and social areas, because that's what our specialty tends to practice as. Whereas in adult neurology, we have very specialized care for the epilepsy, but it is not as integrated as it might be in pediatrics. So this is quite possibly what the actual transition in complex epilepsy syndromes starts to look like. There are so many areas that we would have to look at and really include in our approach into saying, all right, right now we have a complex epilepsy syndrome here. Who is going to take care of all of these separate issues that the patient has to navigate through? Who's taking care, and how do we transition that easily? So, starting with the age. Well, as I mentioned before, once you get into adolescence, you start getting more independent. As the young adult is gaining more independence, there are all the questions and navigating the resources independently that has to be facilitated. And that's on us, that's on the medical system between the child and adult neurologist to be able to offer those resources for that adolescent who's suddenly becoming more independent and taking on their own care in their own hands. Mind you, that individual has just undergone puberty, and the changes that come with puberty, the sexuality, the understanding their own body, and how their epilepsy is impacting their own growth and progression. So when we talk about the actual epilepsy syndrome, we have to think about the age of onset of the epilepsy. How long has this patient had epilepsy, and how long have they been dealing with this? How has that epilepsy clinically evolved? Has it been under control? Have they had a very difficult time trying to control it? Is there any, are there breakthrough seizures? How often do they have status epilepticus? What is that clinical evolution? What is the status of their epilepsy as they transition into adulthood? Also, how has that impacted their psychological development? Are they able to understand all the adulting that needs to be done? Are they capable of it? And will they be able to transition into adulthood, into an adult psyche? Again, as I mentioned, how do drug-resistant epilepsies fare? If you've been struggling with control with your epilepsy and seizures over years and years and years, how does that change once you become an adult? Does it get better? Is it only worse? Is it longer? Those are things that we have to think about and prepare for. How does that impact the behavior of that individual who is going through years and years of drug-resistant epilepsy? And then to suddenly change, how does that impact the behavior? We talk about, and then when we talk about behavior, we come back to mental health disturbances. Those are, we understand that those are very, very important comorbidities that we have to deal with. If there is angst and anxiety, depression, and other comorbidities that have to be, controlled and taken care of along with the epilepsy, how does that impact the transition of care? Are your adult providers going to be able to address the anxiety of youth, of adolescence? I believe Dr. Fried was able to talk about some of the adulting that happens with driving, employment. What does it mean to have epilepsy as an adult? What is your social place with this condition? And all of a sudden, it's a whole new life with a condition that you've had even while you were a child. So how does that impact your quality of life? We talk about, the medical part of it. What are the medications that we use? There's changes in medications, the type of treatment modalities. We're looking at an entire change in the approach to the epilepsy. So there are a lot of different points here that I think as a team, both the medical provider, whether it is the child neurologist or the adult neurologist, in conjunction with the patient and the patient's caregiver, the family, need to come to a consensus too. So I was mentioning there is quite a difference even in the treatment approach to epilepsy, whether it be the adult neurologist or the child neurologist. As a child neurologist, there are many, many medications that we use that are actually sort of off-label or haven't necessarily been FDA approved specifically for younger children. It's because most of the, trials end up starting out in adults. And there are very few medications that we use that have been specifically studied in pediatrics. So we sort of, adapt them to our use in child neurology. But a lot of these medications, you might notice as you transition into adulthood, all of a sudden you have so many more medications available to you because they have been studied and trialed much more in adults. And that actually may be the answer to controlling your seizures, that you have not had the access to these medications over your childhood. Again, how we dose these medication even changes. In adult epilepsy, it's, again, the medications are dosed differently, because in childhood, it's weight-based. We consider, other comorbid conditions. And so, for example, as an adult, you may end up being on more medications for other conditions, and therefore we look at how your epilepsy medications may interact with those. Whereas in children, we may not have as many other medications for other conditions. However, the medications might be limited by weight, by age, and how the physiology or the body composition of a child differs from an adult. Again, if a child has had epilepsy and is so used to having a liquid medication to control their seizures, all of a sudden you might have somebody where they just automatically prescribe pills, and because it may not be considered that you need to you're not used to taking pills. So these are things that, little changes that happen that, not all of us might be very aware of, but may make a huge difference in that transition, making it easier. Also, the responsibility of taking that medication. As little kids, we're used to having the caregivers, the parents, guardians, actually administer the medication. So they remember, and hats off to parents who can actually remember to give the medication. But then as the child grows up, they start to take on that responsibility, or they must take on that responsibility for their own medications and epilepsy care. So along with remembering, okay, I'm going into high school, I'm going into college, what else do I need to do? Oh, I need to remember to take my own medications. I need to remember to have a routine wherein I'm taking care of my own health, and I may not have my parents or people remembering for me. And that's a lot of pressure as you're transitioning care. It's funny. One of the things is, I believe, once you get into adulthood, some of the ways we look at treatment and management modalities for epilepsy, it shifts. As child neurologists, and probably even as caregivers, surgical interventions are less likely to be the first go-to, only because we worry about that child's young brain, and I believe, historically, even child epileptologists have taken a slower step towards surgical intervention and surgical control of epilepsy. And, as you become older, I think there's a much more bigger acceptance of surgical intervention, surgical options for control of epilepsy. Thankfully, now with much more technology and much more less invasive type of treatment modalities, we're able to consider surgical intervention on very young children to help control epilepsy. Again, even with the neuromodulation, like vagal nerve stimulation or responsive neurostimulation, all of these, the question is, how young can you place these neuromodulative devices in? What if you have a 1-year-old? Is the device small enough? So these are other things that maybe as an adult isn't that much of a big deal. And so you have other options, and therefore, hopefully a better likelihood of control of the seizures. We've heard about the ketogenic diet, Atkins, and diet therapy for controlling seizures. Interestingly enough, this is one thing that I think the children with epilepsy have a little bit of a hand over the adults in this, because we've been very, very readily using diet therapy in younger kids with intractable epilepsy, and only lately has the diet therapy been much more studied in adults, possibly because adults are sort of set in their ways, and staying on a diet, I guess, is universally a lot more difficult once you're set in your ways. And the question is, how easily can an adult get into ketosis as opposed to a child? But there have been a lot more studies, again, across the age span, with adult therapies starting to be investigated by child neurologists, and likewise, adult neurologists are starting to look at things. How can we adapt some of these things that work so well in children to the adult population? Now, here are some other, sort of things that we may not necessarily think of right off the bat, that actually make a difference. And this is the difference you're going to find during transition, right? So for example, there are behavioral challenges that make regular care of epilepsy, including blood work, EEGs, and MRIs, difficult. So the question is whether, when we talk about a patient who has a complex epilepsy syndrome along with comorbid intellectual or developmental disabilities, the question is, how does that person get blood work done? How easy is it to get an EEG done? How easy is it to get an MRI done? There are some individual patient-related challenges, right? So if a young adult is intellectually or developmentally disabled, then possibly getting blood work or EEG, having them sit still for an MRI or EEG may be very difficult, and we may need to adapt other procedures with sedation, possibly, to help get those things that we need. For example, many adult specialists in emergency departments don't allow family members in the exam room. And the young adult might actually have to be admitted to an adult floor as opposed to a pediatric floor, and not be allowed to have a caregiver or a family member stay over in their room overnight. These are little changes that I think impact the care during this transition. I can tell you, as a parent myself, it's very difficult to think that when you've been taking care of your child's health needs, and suddenly they're going to have to do it all on their own. The question is, how does that transition happen easily, both for the caregiver and the patient themselves? Do they need that extra support with the family member? And so how do we approach that? Especially in emergency situations, or even a regular doctor's visit. Does the patient go to the doctor themselves? Is their parent allowed? Is their family member allowed in there? Those are all questions we ask and we have to come to terms with. Typically in adults, we don't think about getting MRIs with sedation, or under anesthesia. Whereas typically in kids, that's something we're always thinking about. The question is that patient going to be able to get these MRIs without sedation or anesthesia? Is that a separate thing that the adult neurologist does have to consider? And even in the hospital, the staff should be trained to work with adults with neurological conditions, including intellectual and developmental disabilities or autism. So we go from a very family-centered care to an individualized person-centered care in adulthood. And that's something that every member of this team, including the providers, the healthcare providers, and the family members and the patient themselves, should really be part of. So, for example, what are things that we can look at on our side of the healthcare system? Some concerns that may interfere with optimal transition include lack of nursing or social work services, institutional financial support, and time constraints for pediatric and adult physicians who treat epilepsy, and the provision of multidisciplinary care. What does that mean? Well, we've obviously seen that it takes a village, right? And so do we have all the resources for this village to help with the care of transitioning this patient with epilepsy from a pediatric setting to an adult setting? What else needs to happen? You're just not simply changing doctors. You are changing nursing care, you're changing social care, you're changing, how much time that doctor can spend with you. So that means a change in the overall healthcare system as well. So, and some of the consequences of poorly organized transition beyond suboptimal seizure control may include an increased risk of sudden unexpected death in epilepsy, poor psychological and social outcome, and inadequate management of comorbidities. Now, what does this mean? That means if I, as a child neurologist, don't properly collaborate with an adult provider, then it's not just that my patient will get suboptimal seizure control and may not be able to refill their medications or may not have optimal seizure control, but other risks that are associated with epilepsy just increase. SUDEP, the risk of SUDEP is higher because there hasn't been proper transition. The eventual social outcome, eventual success in that patient's life is dependent on how well that transition goes. So some of the factors that might negatively impact transition include the lack of information about daily life in adulthood. If we don't talk about driver's license, contraception, sexuality, career, what are you going to do in life? How do you function as an adult? And how do you function as an adult with epilepsy? Growing up is as tough as it is. And then when you have to navigate, so many different paths to both control your epilepsy, to, make the quality of life as best as it can be, there's a lot of factors that play into that. Weak transition preparation in the pediatric system. So if I don't take the responsibility upon myself to help my patients understand what it is to be independent and take on that responsibility themselves, if I don't, teach whether it's the patient themselves or their caregivers exactly what is required of them to lead a productive adulthood, then I'm failing on my part. Not just prescribing medications to control their seizures or taking care of them well under my care is not where my responsibility stops. I need to make sure that I have taught my patients well to take on that responsibility of adulthood and living with epilepsy in adulthood themselves. We have to consider, does the person who is going to take on the responsibility of care medically of my patient, do they understand and do they have good knowledge of pediatric epilepsy syndromes? Is there global support for patients with intellectual disabilities and the multidisciplinary care that we were able to offer that child as they grow into adulthood? Does the adult healthcare system have that, all of those opportunities and resources? So as I mentioned, a lot of youth are not ready for the patient-centered versus family-centered model of care. The adolescents may not have an understanding of the consequences. Parents and their doctors might be actually overprotective. So solutions, what are we supposed to do? It is the responsibility of the adults taking care of this child transitioning into adulthood. It is our responsibility to gradually introduce, that responsibility to these teenagers as they start, transitioning into young adulthood. Introduction of individual office time, beginning with visits in the early teens, wherein, they start getting 15, 16 years old, you have them start coming alone to the doctor and have some, one-on-one time. Have the patient take the responsibility of making those appointments and keeping those appointments, discussing their epilepsy care with their provider, with their doctor, understanding what their own responsibility is, and it's our responsibility as the adults to provide training to meet the psychosocial needs of these young adults, using local resources. The Epilepsy Foundation Camp is an excellent resource for understanding, all the needs of that teenager who's suddenly exposed to the pressures of the responsibilities of adulthood and taking care of their epilepsy. These kind of camps, these kind of local resources encourages self-advocacy and independence. The self-care status of adolescents with epilepsy during the transitional period is closely related to the coping style and family resilience. So it's one thing for that adolescent with epilepsy to start with self-care, but it also depends very much on their family and how the family and even their child neurology provider, how they have coped with the epilepsy and the care of that epilepsy. If we have always included that child and that adolescence in their own care, medical care, then that really established a good foundation for their easy transition into adulthood. It is really essential to better prepare youth and the caregivers for the adult model and to arrange as much as possible prior to transfer. For example, where are they going to be living? What are they going to be working at? Do they have any other care, or are they just let off alone into the world? Do they get any respite? Who do they turn to? It's tough adulting, and it's even tougher adulting with epilepsy for the first time. When we have so many people who have been through these experiences and have the resources to help, those transitioning into adulthood, I think it is our responsibility to prepare them and offer all the experience that we have. Currently, there are a lot of, limitations of resources within the healthcare system that needs to be acknowledged, and we need to be able to handle those parameters. We need to be able to go around it. Now, what do I mean by that? In the healthcare system, for example, when I talk about, well, I will see my patients, technically, I tend to keep them longer till I know that they've been established with an adult neurologist. The question is, what age? Is there a magical age that we cut off at? One day, before their 21st birthday, are they seeing me, or their 18th birthday, are they seeing me? And then, the minute they turn 18 or 21, do they have to go suddenly see a new person? And do they have any inkling, or are they supposed to find them themselves? These are areas wherein I think we as the healthcare providers need to step up, and in conjunction with the caregivers, with the individual themselves, need to figure out, and much earlier than D-Day, than the 18th birthday, than the 21st birthday, we need to sort out, okay, what is our plan? Who do we think we would like to transition to? Is it within the same system? Is insurance going to change? How do they practice? Do they know who you are? Do they know who your doctors are? Does your general medicine care change as well? Are you still under the care of your pediatrician? Does your adult, the new neurologist, do they know your pediatrician and your other doctors? Those kind of things need to be started and discussed much earlier in the course of this adolescent's care. You know, we also start thinking about, there's a lot of other changes going on at that same time. You know, we talk about schooling, you know, well, is this individual with epilepsy, have they been in a special education school? Have they been in a vocational school? What's happening? Are they going to college? Are they going to away to college? Are they going to continue in special education? What resources do they have for that? Are they going to be on their parents' insurance? Do they have to find insurance of their own? And which doctors take their new insurance? These are all very, very important considerations. And I think these are all concepts and matters of discussion that have to be had, you know, well, in the very early teens, regardless of whether that child is actually going to outgrow their epilepsy and not need an adult neurologist or not. I think that's just part of overall transitional care. Now, you know, as child neurologist, child epileptologist, you know, the healthcare system has actually been rather aware of the need for a transition of care program. A lot of the organizations, the American Academy of Neurology, the American Epilepsy Society, the Child Neurology Society, Child Neurology Foundation, all of these organizations and providers and resources that take care of children with epilepsy, they have understood, and I will say they are starting to understand the importance of a well-established transition of care program. And so they've put together an advisory committee that actually has 8 common principles of the transition of care. 1, the expectation of transition. Okay, so, and that is the expectation of every person on that team, including the provider, the healthcare provider, the caregiver, and the patient themselves. Yearly self-management assessment. So starting at age 12, every year, we have a full-blown assessment. How well managed is the epilepsy? How much responsibility does that individual, does that team with epilepsy have? How much of self-care are they able to navigate? And that should be assessed every year, starting from year 12, including an annual discussion of the medical condition and age-appropriate concerns. You know, there are a lot of changes that happen through puberty. So as the years go by, we come and have sort of an update. Where are we at with our medical condition and our age? We talked a little bit about legal competency, right? What does it matter? We talk about guardianship when a patient's not, you know, attains the age of 18, but is unable to care for themselves. So that is something to consider and evaluate. And then we keep an annual review of this whole transition plan. Do, you know, as a child neurologist, do I know what I'm supposed to do? I can't just let them go off into the world without knowing who's going to be taking care of their medical needs, who's going to be that adult provider. We need to come to consensus that this is the doctor that they're going to see. This is the hospital that they're going to go to. This is the insurance that they're going to be on. And yes, this adult provider that the team has chosen or the patient has chosen does accept their insurance, does accept, this patient. Do they have all does the adult neurologist have all the records from the child neurologist? Do they have all that information? What has been the care of this adolescent all through the time of care of the epilepsy? You consider it, what does the adult provider need? And have we done a good job in transferring all that information, as well as setting all of this up? So again, I think, all of this happens. It's interesting. We talk about, okay, we have a transfer packet. We have all the medical records. We have all the tests, all the medications, all the trials, everything that's worked, everything that hasn't worked. And we sort of say, okay, this is part of your transfer packet. This is all your information. And now with electronic medical records, it's easier to send over so that your adult neurologist can actually see everything that's been done and take it from there. However, it's not like, here, go see that doctor, nice knowing you, goodbye. I think it is our responsibility to continue that discussion with the child neurology team and the adult neurology team, both having very frequent discussions in easing out that transition of care. So actually, there are a lot of neuroscience departments, especially in larger hospital systems, wherein both adult and child neurology and adult epilepsy and child epilepsy are all working sort of in one department, and it makes for very easy transition. For example, where I work, I can very easily, I work in the same, practically in the same office building as some of the adult epilepsy providers. And we have started a transition program wherein I can physically go be with and discuss a transitional patient with their adult neurologist who they have decided that they're going to start seeing. And it makes a lot more sense when we all have an open conversation and discussion. We've found this very helpful, at least both on the caregiver's part and the provider's part. I think an adult neurologist would certainly appreciate as much information as we can give them, saying, oh yes, they just had an EEG and this is what we've done, this is what we thought. We've transitioned, we've given them this medicine, that worked, that didn't work. These are some of the side effects that they have experienced. And so maybe we can start thinking about what might be helpful to improve this patient's seizure control and eventual quality of life. And so that's typically what the idea of this transition of care program was meant to achieve. And with that, those are pretty much my slides. That is kind of some of the topics I wanted to talk about from the perspective of the caregivers, including the child neurologist. What are we supposed to be doing? How do we look at this? What do we think is our responsibility? And I think you know, now that we have such technology to be able to share information, I think we should be a lot more open-minded and start that transition very, very early on, considering, you know, again, like I said, as a child neurologist, I'm always looking to see, I understand that I have in my care a very precious being that is going to be growing, developing, and eventually leading an adult life. And I need to be able to offer that being every resource I can to help improve their quality of life, both as a child and as they transition into adulthood. And that's what I consider my responsibility. So, and this also goes partially, you know, sort of kind of like the parent's perspective as well. You know, it's tough to let go. But we need to understand the importance of teaching our children that independence and self-care. So we need to involve them in their own care very early on. So that they are able to navigate the resources for themselves easily, and it doesn't come as a shock to the system as they're growing up. So yeah, that pretty much finishes my talk. I talk a lot, sorry, but
all right, well, thank you, Dr. Akila. At this point, we'll open it up to questions, both for those who are joining us on Zoom or anyone in the room. If they have any questions for Dr. Akila and her presentation.